Morning, everyone. Today we will discuss the shoulder dislocation. And Dr. Prabu, senior resident. Good morning, everyone. Today we will discuss the shoulder dislocation. I am Dr. Prabu, senior resident, Department of Orthopedics. So, shoulder joint. It's a ball of a joint. There are three joints sticking of the shoulder. Diaphragm, acromioclavicular, sternoclavicular joint. Shoulder joint is a very mobile joint, hence it is also unstable. As the mobility increases, the stability decreases. Stabilized by rotator cuff muscles such as infraspinatus, supraspinatus, teres minor, and the subscapularis. What is shoulder dislocation? It is a condition in which head of the humerus is placed out of the glenohumeral joint cavity. This is called as shoulder dislocation. We'll see about the anatomy of shoulder joint. Coming to the anatomy of shoulder joint, as we have seen, there is a glenohumeral articulation and sternoclavicular articulation. And here we can see the humerus, scapula, and the clavicula. This is the humerus. This is the scapular bone. This is the acromion process of the scapula. This is the coracoid process, and this bone here is the clavicula. Okay. Coming to the anatomy of the shoulder joint, this is the head of the humerus. Here there is a greater tuberosity. This is the surgical neck. This is the lesser tuberosity. Here there is the supraglenar tubercle of the scapula. This is the first rib. Infraglenar tubercle, lateral border, medial border. So in the previous X-ray, we can see that the glenohumeral articulation is well maintained. This is the X-ray of anterior shoulder dislocation. Here we can see that the humerus is dislocated anteriorly and it is lying in the infraglenar position. So this is an anteroinferior shoulder dislocation. Coming to the anatomy. The structure of shoulder joint can be imagined to be like a golf ball and a tee. At any time, only 1/4 of the humeral head articulates with the glenoid. Hence, the bony articulation is inherently unstable, and the primary restraint dislocation is provided by the soft tissue cover around the joint. Any joint, we can tell that the stability is maintained by bony structures, which are the static stabilizers, and there is a dynamic stabilizers. The dynamic stabilizers of the muscles around the shoulder joint helps to stabilize the joint dynamically by its action. Important structures that stabilize the shoulder joint include primary or static restraints and secondary or dynamic restraints. Static restraints are the joint capsule. A strong capsule encloses the joint all around to keep it located. Glenoid labrum, this is a fibrocartilaginous ring around the glenoid that encircles it to make it cavity shape. Glenoid is deepened to almost 50% by the presence of labrum around it. Glenohumeral ligaments. These are a group of ligaments, namely superior, middle, and inferior glenohumeral ligaments. They run across the anterior and inferior aspect of the shoulder from glenoid margin to the neck of humerus. They reinforce the anterior capsule added to the anterior stability of the shoulder. There is a negative intra-articular pressure. The joint has minimal amount of synovial fluid such that there is a cohesion force between the opposing surfaces. So the static visions of joint capsule, labrum, ligaments, negative intra-articular pressure. The important dynamic restraints include rotator cuff, deltoid, and biceps. We have seen the rotator cuff muscles, which are supraspinatus, teres minor, and teres major. And similarly, we have seen in the other deltoid muscle and biceps. The mechanism of injury. Traumatic anterior shoulder dislocation mostly results from a fall on outstretched hand with abducted and externally rotated shoulder. Convulsive disorders and electric shock are a common causes for a posterior dislocation. Inferior dislocations result from hyperabduction injuries of the shoulder. Types of shoulder dislocation: anterior 95%, which are subclassified in subcoracoid, subglenoid, subclavicular. Posterior is 4%, inferior is less than 1%. Anterior dislocation, subcoracoid. Humeral head sits anterior and medial to the glenoid, just inferior to the coracoid. Approximately 60% of the cases are subcoracoid dislocations. What are the subglenoid dislocations? Humeral head sits inferior and slightly anterior to the glenoid. That the humeral head has also traveled medially. 30% of the cases. Here we can see that this is the subcoracoid anterior dislocation. Humerus sitting anterior and medial to the glenoid and inferior to the coracoid. Here we can see the subglenoid dislocation. Humeral head sitting inferior and slightly anterior. Okay. This is the inferior and minimal anterior to the glenoid. Here you can see mostly inferior and just anterior. Okay, and to inferior and below the coracoid. Here again another example of showing the subglenoid dislocation, and here there is a subcoracoid dislocation, which is the most common. This is a subclavicular dislocation. Let's see about the posterior dislocation. There are different mechanisms by which a posterior dislocation can occur, mainly seizure, blood perfusion. The posterior dislocation presents with flattened anterior shoulder and prominent coracoid. And easily, though unrecognized, and the patient can present to you at a later date as an untreated posterior dislocation. One of the conditions can be easily missed. Patients who sustain posterior dislocation keep their shoulder in adduction and internal rotation. External rotation is limited. Coracoid process may be more prominent and humeral head may be palpable posteriorly. In the routine anteroposterior X-ray, posterior dislocation often is missed initially as the humeral head appears to be almost normally aligned with the glenoid. Light bulb sign. In the posterior dislocation of the shoulder, the humeral head remains in internal rotation and looks like a light bulb. This is because of the internal rotation. Here you can see the light bulb. There is vacant glenoid sign. The anterior glenoid looks empty. There is a tension. When widening of the intrahumeral space, there is light bulb sign that is facing back. It's like internal head. Okay. Usually, normally, you'll be able to see the fibrosity,
And due to the internal rotation, the reciprocal velocity is not visible, and there's a smooth contour, which is known as the light bulb. Another sign that may guide is the rim shape. If on anteroposterior view, space between anterior rim of linear humeral head greater than 6 mm, highly suggestive of posterior dislocation. Now we can see about the inferior luxation recta. This is a rare type of injury in which the humeral head lies inferior to behind, then with the hyperabductive humerus. The arm locked in full abduction. Patient typically comes in emergency with abducted and locked shoulder supported by other hand over his head. So you can see the luxation recta is the inferior section of shoulder. Presents with the hyperabductive humerus. So you can see that the shoulder is affected and locked shoulder is supported by the other hand over his head. Mechanism of injury is important in diagnosing type of shoulder dislocation. The position of arm at the time of injury will dictate how the dislocation happens. Anterior arm abducted and externally rotated. In posterior dislocations, arm is abducted and internally rotated. In inferior dislocation, arm fully abducted, elbow often flexed or behind the head. These are the common mechanisms. I repeat, in anterior, the arm is abducted, externally rotated. In posterior, the arm is abducted, internally rotated. In inferior, the arm is abducted, and the elbow often flexed on or behind the head. Signs and symptoms. There is loss of normal contour. Complaints of severe shoulder pain, range of movement decreased in the level. Palpable humeral head. Positive apprehensions. Diagnosis based on clinical test or position of affected shoulder. Radiograph, X-ray shoulder, ATV, MRI. In patient with lateral shoulder dislocation, we take MRI to look at the dynamic structures, mainly the rotator muscles, deltoid, and the biceps, the atrophy, the labrum damage, the soft tissue injuries can be taken up by the MRI. CT shoulder in patients with lateral shoulder dislocation, we take a CT of shoulder joint, look at the linear bone loss. If there is bone loss, then the static structures stabilizing the joint is affected, and hence there may be recurrent dislocation, which will appear better in CT. CT is always better for the bony anatomy, MRI is better for the soft tissue anatomy. And provided CT shoulder has an added indication when there is injury to chest and calf, multi-canal devices, and this is Duba's test. Patient is made to place the hand on the opposite shoulder. The examiner then applies gentle lower pressure on the flexed elbow to make it touch the chest. In shoulder dislocation, the elbow cannot be made to touch the chest. So, Duba's test is a simple screening test. This is the Hamilton ruler test. In a normal shoulder, the ruler placed on the left side of the arm will not touch the lateral condyle or the humerus and the acromion at the same time. In anterior dislocation, the ruler is simultaneously touch the lateral condyle of the humerus and the acromion. Here is the ruler. This is the lateral condyle of the humerus. The condyle of the humerus. On placing the ruler on the lateral condyle, it's not touching the acromion. But in the shoulder dislocation, the humerus gets beginning. Really displaced by the ruler and that's the problem. Fracture the content, not touching in normal cases. Dislocated lateral condyle and the acromion can be tested. Cannot test vertical settlement to backside is increased on the dislocated side as compared to the normal side. Axillary nerve injury, anesthesia in the regimental badge area. This is the regimental badge area. Axillary nerve. When there is a shoulder dislocation with axillary nerve injury, we have active anesthesia in the regimental badge. Since we usually check the sensation in the regimental badge, and if there is any defect, there is any loss of sensation, anesthesia, paresthesia, then we always see the regimental badge. Posterior dislocation of shoulder. Here, the external rotation is restricted by the strong prominence in the posterior deltoid. This is the posterior dislocation. It's an axial view. So, you can say that it's a very posterior. So, this is the protoid, and this is the anterior. This is the posterior. Now, how do we manage the dislocations? Initially, any management in orthopedic emergency consists of analysis and muscle relaxation. Once the patient is found, then we perform a reduction maneuver. Surgery is indicated in patients with recurrent shoulder dislocation. Anterior shoulder dislocation reduction maneuver. This is a both chest maneuver. In supine position, arm is kept by the side of the body and elbow is flexed to 90 degrees. Now slowly externally rotate the shoulder by grasping the wrist supporting the elbow until resistance is felt. Now internally rotate the shoulder. Bring the patient's hand towards the opposite shoulder. Few more legs sits back into the air with the palpable body. Okay. Elbow to the side of the body, flex to 90 degrees, external rotation of the shoulder. Once the resistance is felt, then the internal rotation of the shoulder, few more legs sits back into the air with the palpable body. So here we see the chest model. Initially, there is arms held towards the side of the body. It's external rotation, and then there is an internal rotation. And patients, surgeon is making the patient's arm to touch the opposite shoulder. So this is the new test. Once it is reduced, then it will be the patient will be able to touch the opposite shoulder. The pneumotic steam, traction, external rotation, action, internal rotation. There is another maneuver, one of the niche maneuver, in supine position. Steady downward traction at the elbow, slow gradual external rotation, and contraction of the shoulder. Steady downward traction at the elbow,
gradual external rotation and contraction of the shoulder. At the elbow, combined with slow gradual external rotation and contraction of the shoulder. So here we can see that the affected, there is a downward force and there is an external rotation. Hippocratic method. In supine position, surgeon holds the patient's hand with the arm and 30 to 40 degrees of abduction and gives sustained traction for about 1 minute. Counter traction is given by putting the surgeon's heel into the patient's axilla. This acts like a fulcrum and the arm is gradually adducted. Internal rotation and external rotation of the shoulder may aid in reduction. This is less favored nowadays as it is more painful method and the brachial plexus and wrists are at great risk during the maneuver. So nowadays we don't perform this Hippocratic method just for discussion of theory. Because of the risk in when you're keeping the foot in the axilla, it may injure the vessels, maybe the axillary vessels and the brachial plexus, which can have devastating consequence to the patient. So here is a demonstration of Hippocratic method, where the surgeon places his foot in the axilla and gives a traction. This is the traction and this is the counter traction. And then gradually he does the internal rotation, external rotation until the shoulder slips back into position. This is the Stimson's gravity technique. In front position, patient's arm is kept in forward flexion and external rotation. Suspended at the edge of table and 8 to 10 kgs of weight or manual traction is applied to the wrist. Once it is done, the shoulder reduces and this is known as Stimson's gravity technique. After treatment, after the reduction, the arm should be fastened to the chest with a body bandage for a minimum period of 3 weeks. Failure to do this leads to development of recurrent shoulder dislocation of the shoulder due to the faulty healing of the capsular bed. Complications. rotator cuff tear, shoulder stiffness. In young patients, recurrent dislocation is the most common complication after first episode of dislocation. Usually occurs when there is any associated
bone injury, like there is ulnar bone loss, then we have a recurrent shoulder dislocation. In fact, recurrent shoulder dislocation is the overall most common harmful complications in this population. Osteoarthritis of the glenohumeral joint can be another long-term sequelae of shoulder dislocation. All patients should be thoroughly examined for neurovascular injury, mainly the axillary nerve injury, where we have seen the regimental badge, anesthesia. That is the most common acute complication when presented in 75% of the cases. Can be detected by absent deltoid contraction or better by loss of sensation of the skin of small part on the lateral upper arm, mainly the regimental badge. After axillary nerve, the other nerve that is injured frequency is suprascapular nerve. Coming to the prognosis, approximately 80 to 94% of the patients younger than 20 years at the time of initial dislocations have a recurrence. Of patients younger than 40 years, 26 to 48% develop recurrent dislocation. Dislocation recurs in only 0 to 10% of the patients older than 40 years. Minor trauma that results in a dislocation is associated with 86% of the recurrence rate. Now, how do we manage recurrent anterior dislocation of the shoulder? It's a very common complication of anterior dislocation. Acute posterior dislocation of shoulder is mostly traumatic in nature. Therefore, in many patients, the joint dislocates even with minimal trauma due to failure of important stabilizing resistance to healing. Recurrent dislocations are associated with following pathological changes in glenohumeral joint after the acute episode. There can be a Danforth's lesion, commonest lesion, which is present in almost 90-98% of the cases. There is detachment of the anterior inferior labrum from margin of glenoid that produces recurrent anterior dislocations. So here we can see this is the labrum. There is hand, so this is the labrum. Here we have a anterior inferior part of the labrum. There is a tear known as the Danforth's lesion. Is the T-Stax lesion. A defect is excavated on the postlateral aspect of the humeral head due to repeated impact against the anterior glenoid in patients who have several episodes of dislocations. Thank you. Coming to the summary of shoulder dislocations. The shoulder can dislocate in there is an anterior dislocation, there is a posterior dislocation, there is an inferior dislocation. Inferior dislocation is also called as axatio erectum. The shoulder consists of static stabilizers and the dynamic stabilizers. Static stabilizers are the bone, ligaments, capsule, and the labrum. These are the static stabilizers. You can see bone anatomy, glenohumeral joint. Here there is a affirming process of the scapula, and there is a clavicle. So shoulder comprises of glenohumeral, acromion clavicle, and sternoclavicle. And the dynamic structures are rotator muscles and supraspinatus, infraspinatus, penis minor, penis major, and the subscapulars. Supraspinatus, infraspinatus, penis minor, and subscapularis are the rotator muscles. And we have the biceps and deltoid giving dynamic stability to the shoulder joint. If there is any disruption in these structures, we get a dislocation. And if there is a damage to the static structure, namely the glenoid bone loss or labral tear, then you have what is known as the recurrent shoulder dislocation. Here, this is a Danforth lesion. It is anterior tear in the glenoid labral. Similarly, if there is a lesion in the humeral head, this is known as T-Stax lesion. Here you can see that there is T-Stax lesion, usually occurs in the posterior part of the humeral head. As the humeral head slips from anterior inferior and posterior part of the humeral head engages with the glenoid, and there will be a lesion in the humeral head. T-Stax lesion. These are some of the causes of recurrent anterior shoulder.